Good evening. My name is Reggie Jones. I'm a graduate student at Southern New Hampshire University in the Masters of Public Health program. Throughout my program, I have focused my research on mental health topics. Now, at the end of my practicum, I'm presenting my PowerPoint slides that I put together on the data analysis that I conducted on finding the impact of clinician communication on people with diabulimia in the clinical setting. So I'll be sharing my PowerPoint slides with you. One moment. Okay. So this data analysis is called Diabulimia Impacted Clinicians' Use of Language. It will be the analysis and a discussion. Just a brief introduction. Diabulimia is a purging eating disorder among populations diagnosed with diabetes. The purging mechanism of the disorder is the restriction of complete omission of prescribed insulin treatment as a weight control or a loss method. This type of eating disorder is only found in people that are diagnosed with diabetes. Therefore, it can't be really compared well with other mainstream eating disorders such as anorexia and bulimia. Poor communication practices in the clinical setting can have consequences for the timeline of effective treatment for people struggling with an eating disorder, such as diabulimia. The research question that I used in the data analysis was, how does the use of language and communication in a clinical setting impact the doctor-patient relationship? So I conducted a literature review on this topic, and 6 major themes came very apparent throughout the whole research. And these 6 themes are stigma, which is characterized as feelings of shame or as negative characteristic about a person. Bias, the preference or attitude towards someone or a characteristic of someone. Label, giving a person a characteristic, whether true or false. Language use, to express oneself. Microaggression is subtle negative behavior toward a marginalized group. Comments and messages are remarks given as verbal or nonverbal. So I set up the 6 themes in this hierarchical clustering to show the relationship. What I'm looking for is the impact of communication with diabetes and diabulimia. So in the literature review and the subsequent analysis, I used thematic analysis that was used for the purpose of identifying patterns throughout the literature that is relevant to the research and its similarity to each other. This approach also allowed me, the researcher, to apply personal knowledge to identifying the data trends. With the researcher involved, myself, directional drift is avoided and the coding stays consistent and relevant, meaning I wasn't going off in rabbit holes when I was putting everything together. The qualitative data found in the literature review was formed into this pattern to develop the clusters of comparability. The first 2 levels, the impact and communication of this framework, represent the overarching topic. The mid-level, the diabetes and diabulimia, are there, and then the lower level displays the granularity of the traits from clusters 1 through 3 that occur in the interactions between clinicians and patients of the target population, which are people living with diabulimia. I conducted a qualitative structured coding. Each of the 6 themes found through the literature were transcribed to questions, the research impact and prevalence in diabulimia, by measuring the frequency of positive and negative attributes throughout each of the articles. Each theme was used as variables and color-coded within 368 entries on the spreadsheet. I can share that spreadsheet. 1 second. This is my Excel spreadsheet. And what I did is when I counted through each of the themes, I put them over here to the right and I color coded them as to which theme they were. There's 368 themes all the way down that I took from the literature review and interviews. And since I wanted to find out the positive and negative of each of them, if the entry connotation was a positive or negative, that's how they were ticked. I did that all the way across. Let me go back to the slides. That is not the slide. Hang on one second. Sorry, just one moment. Okay, so back to the slides. Here's where the positive or negative aspects came in. To measure whether the themes impact diabulimia and its prevalence, the coded variables were set to positive or negative connotations of each entry, just as I showed on the Excel spreadsheet. Positive connotations can have as much of an impact on diabulimia as negative connotations. Positive connotations can be viewed as pathways towards communication improvement for what is already working in the clinician-patient relationship within the clinical setting. Meaning, if it was a positive connotation, it could have been a guideline that was set on how to communicate properly. The negative attributes of a theme can illuminate where best practices for implementation strategies can occur to strengthen the clinical relationship when working with people living with diabulimia. So the use of language in the clinical setting is important to preserve a trusting relationship between people and their professional providers, from the staff that greets you to the provider and the laboratory personnel. Everyone is part of the team when you go into a clinic. And each one can bring something unique to the dynamics of a healthy communication. Your communication with who checked you in can really set a tone on how the rest of your appointment can go, as well as whoever is triaging and doing blood pressure checks and downloading your glucose management devices. So through the data analysis of these 368 entries, I found that 30% negative impact regarded stigma in the clinical setting. This was a surprise to me, as I felt like the negative impact would have been the use of language that clinicians use with their patients. 20% related to the use of language towards people seeking care from clinicians. So it was the second step down. Microaggressions occur in 15.5% of the literature, which signified how clinicians may be outwardly displaying the frustration and how they feel helpless in treating the complexities of people with diabulimia. This is something that could be experienced as negative tone, body language, like unnecessary sighing, things like that. They can really put a patient in a place where they feel like they have to defend themselves. Smaller negative impacts that were measured were messages, bias, comments, and labels. They were at a smaller amount, but still very significant. The impacts here, so the positive impacts that made a relevancy to patient care and their health outcomes depend on how communication is directed towards a person and how it is perceived. Guidelines of positive use of language were evident through the reviewing of the literature and were comprised as part of the measurement of positive impact and prevalence. The use of language measured at 17.7% as a positive impact for our target population, and messages comprises 10.3%. Both themes are intricately linked with communication and the barriers that can be avoided in the clinical setting. The other 4 themes that were measured at 1% or lower, they were not of significant value in contributing to this positive impact. So when we talk about messages, we're talking about things that could be verbal or nonverbal. It could be messages from the clinician to the patient that uphold, how well they're doing and empowering. Or you can also do the flip side of negative messages that may be in their medical file that can actually hinder further care down the line from another provider. So we want to make sure that we have more of a positive impact on those messages to empower our patients to see how their self-worth is different than their glucose management. So in the prevalence, so according to the CDC, prevalence and impact are related, but they're not interchangeable concepts when it comes to calculating statistical percentages. The prevalence is used to estimate the proportion of individuals in populations who have particular conditions. And while this impact is used to estimate the burden of the condition or the population, use of language can also be a significant impact on the prevalence of diabulimia, both in terms of the condition, how it's understood, and how it's addressed by the healthcare professional and for society. One way that language can impact the prevalence of diabulimia is through stigmatizing language that contributes to the shame and secrecy often associated with this condition. As people may know, eating disorders are highly secretive with patients, and communicating their needs is not a strong point. So the more you can make a patient at ease, the more that they feel worthy of sharing this information with you. Because the more that a patient with diabetes or a patient with diabulimia can trust their provider, the easier their treatment can move along. If you don't get good communication from your patient with diabulimia, it can hinder that treatment and make it a lot longer for them to recover from diabulimia. This analysis revealed that not only is the use of language important when interacting with people with type 1 diabetes and diabulimia, stigma can affect the clinician-patient relationship at a higher level. People with diabulimia often feel stigmatized and are hesitant to communicate freely about their eating disorder and seek the type of treatment needed to help themselves. The CDC provides a list of best practices for reducing stigma in the healthcare setting. Here are just a few of them. One is maintaining accurate records. A lot of the guidelines show that you should not be putting in quotation marks what the patient exactly said. Another thing is to eliminating stereotypes in all health communication media channels. That means in their patient medical records or communicating with other providers in the clinic. Changing the language of medicine for positive dialogues instead of focusing on all the negative things that the patient has not done in the appointment or outside of the appointment coming in, like their glucose management, not focusing on all those negatives, and find some positives. Be curious about the patient and see what else can be brought to the table to empower the patient. Communicating the facts and leaving out unnecessary jargon, and keeping personal health information on a need-to-know basis to protect a person's privacy, meaning you're not walking around the clinic talking about this one patient who may not be managing their glucose the way that you like it, and certain words are used to describe the patient, such as non-adherent or non-compliant. So in conclusion, whole person wellness and the use of language in the clinical setting are especially critical in populations with diabulimia, a condition where individuals with type 1 diabetes intentionally withhold insulin to control their weight. Healthcare providers that understand the complex psychological and physical factors contributing to diabulimia and approach treatment in a non-judgmental, person-centered manner that considers the patient's unique experiences and needs. The use of language that acknowledges the patient's whole personhood rather than solely focusing on their diabetes management can promote a sense of agency and empowerment. Fostering a collaborative treatment relationship is really important too, to work with other disciplines outside of the clinic. Incorporating whole person wellness practices such as mindfulness and stress management can also be beneficial for individuals with diabulimia, addressing the psychological factors that contribute to the condition as well. Ultimately, by prioritizing whole person wellness and language that supports a patient's autonomy and dignity, healthcare providers can provide a more compassionate and effective care for individuals with diabulimia. Okay, so that concludes the data analysis on there. I want to thank everyone for listening and helping to contribute to the research topic and the data analysis. I'm excited to share my research with you and discuss its implications for public health. I hope everybody has a great night. Thank you.